You're listening to the Men's Mental Health Podcast, The Man Hug.
Welcome to The Man Hug, the monthly men's mental health podcast. I'm Dean McShane.
I'm Dan Cooper.
I'm Ian Pearce-Hayes.
And I'm Conleth Kelly.
Each month we will discuss a different topic related to men's mental health, which will include a guest speaker who will discuss their own personal story. And each month we will also be showcasing an organisation or charity within the Merseyside area who work within mental health to help build your signposting skills. Welcome to this Man Hug special as part of HIV Testing Week. We're joined today by Emma Davey, who is a clinical nurse specialist in palliative care and HIV oncology. We're also joined by John Kelly, who is a peer support worker at George House Trust. So welcome both. Thanks for joining us on the Man Hug.
No problem. Thank you for having us.
Oh, amazing. So we always kind of start by just getting our guests to share a little bit about who they are. So Emma, let's start with you. Tell us a little bit about who you are.
Thank you. So, I've been really privileged to work as a clinical nurse specialist for the last 25 years in palliative care and always worked in HIV care outside of that in a voluntary capacity. And then about 5 years ago, since I have been working at Tertiary Cancer Centre, just noticed that we had a disproportionate number of people living with HIV being treated for cancer and have managed to do some audit and research and get some funding now to work as an HIV oncology nurse, which is like my dream job, to be honest with you.
Yeah, brilliant. And John, a little bit about yourself?
Yeah, so I'm a peer support worker and HIV support navigator for George House Trust. So I've been in the post since May. I first come across George House Trust when I was invited to become a peer mentor on a voluntary basis. I also live with HIV myself, so as a peer support worker, that's really important about sharing my lived experience and just showing people, especially with the newly diagnosed sort of people we see. You know, the HIV is not going to hold you back. It's not going to, cause you any problems as long as you keep fit and healthy and take your medication and, all of the things like, U equals U. So untransmissible means undetectable means transmissible. So thank you, Emma. So I should know that really off by heart. But that's what our message is really. And it is actually a great honour to sort of like do this role, and change those people's lives.
Wow. Yeah, that's amazing. We'll come back to George House Trust a little later on. You can tell us all about it. I think this is going to be an amazing educational session. I think people are going to learn an awful lot from it. We might read some common misconceptions, these types of things, and that's why we put out these specials during these weeks of the year where we have like awareness days, and they're really important, aren't they? So first off, for people that don't know, what is HIV and how does it affect people? So either of you for that one or both?
Yeah. We'll chip in.
No, I mean, so it's a virus and it's usually passed on mainly through sex. Can be passed on through other forms such as shared and needles. It's quite rare though. So that they're the main routes of transmission. It can, if not treated, and progress into late stage HIV. So that then gives that's when opportunistic infections will take over. I could tell my own experience of that if you wanted to at some point, but because I've been there. So I've been diagnosed 16 years ago now. So yeah, it was back when they didn't actually give you any medication until your CD4 count was below a certain amount, and your immune system is then compromised. But so that I did go through a really quite a rough stage, not far after being diagnosed. But yeah, HIV is a managed condition. It is as long as you're taking your medication, and there's lots of different options of a medication for people out there as well today. I think there's about 14 different options. Emma, you might know better than me, but yeah, there is about that. And there's ones that can fit everybody's circumstances and sort of what their needs are. So that's it really. It's just a virus. That's it. It's
Important message I think we both want to get across is that this is a chronic, long-term, manageable condition. If you're engaged with care and taking medication, you live actually with a better than normal life expectancy than the general public. So it's really changed over the last 40 years. It's unrecognisable from where we were. And John talked there about late stage HIV. We don't talk about AIDS anymore. I think historically, people commonly would talk about HIV, AIDS, wouldn't they? And prior to there being effective antiretroviral treatment, if people developed a number of opportunistic infections, their blood counts were at certain levels, they'd receive a diagnosis of AIDS. We don't see that very often at all anymore due to treatment. And we refer to, these days we talk about late stage HIV, so AIDS is really quite an outdated term now, isn't it, John? I think.
Oh, very outdated. I mean, it does trigger a little bit of trauma in my mind, because I was told 16 years ago that you are now AIDS, that you have AIDS, and it wasn't really, because it was Kaposi sarcoma. That's what it was. That's what was happening to me, and I had quite aggressive chemotherapy treatment. Went on for about 18 months, and it was that bad. And because I was severely malnutritioned, I was going towards organ failure, and they were literally saying to me, if you don't respond to this treatment anytime soon, you're just going to die of organ failure through malnutrition, basically. So I was being fed through a tube down into my stomach, through my nose, all sorts of things going on, like multiple pneumonias. I was in and out of hospital. I think at one point I was in there for 4 months in the Royal, and that was the old Royal, back then. So that was like torture in itself, So they actually moved me into a single room on my own as well, because of other opportunistic infections, and I was being restricted on how many people could come and see me. But I had to go through a lot on my own, really. My family were all around me, supporting me, worried about me. I had a partner as well. He was brilliant, but I didn't tell any of my family what actually was going on. And the medical professionals at the time, they just said, if you're worried about telling people that you've got AIDS, then tell them that you've got non-Hodgkin's lymphoma, because you're going to have the same treatment. So that's what I'd done. And I had to live that lie, for that whole time. Only me and my partner knew what was actually happening. And my mum went along. This is, and my mum came along to every chemotherapy session that I went to, because my partner was at work and trying to keep the house going and all this sort of stuff, because I wasn't working, obviously, at the time.
Do you feel you'd have more confidence now to tell them? Or
I've told them now, because when I come to work for George now, so when I came to work for George House Trust, I thought, I was telling my sister that I'd gone for the job, and I'd got the job, and she was like, I'd already told her anyway, so she was fine with it. I said, she was like, well, my mum's going to be asking, isn't she, if you've got this new job? So I thought, I'll have to tell her now. But I had to get used to being open about it because of the job that I do.
I think things have changed so much, haven't they? One of the questions we've got down is, what's the difference between HIV and AIDS? We've answered that clearly now already, but obviously growing up in the 80s, when everything was so new and so confused, and that there was just so much misunderstanding, misinformation, scaremongering, that I think that knocked everything further back than it could have done. Everyone was so scared that nothing was being done to actually improve people's lives, and I've talked about it a couple of times on podcasts previously, and I have vivid memories of the advert with the tombstones.
Tombstones,
That really affected me as a kid. And me. And how wrong was that as a public health message? And things like that just knocked back the understanding and people wanting to then seek help and support and the care and develop research to then go on and find treatments to help support people. And so
I mean, we know it's really, I think, important what you've said there about it being quite triggering, because I think for people who are long-term survivors of HIV, we know that from acquisition, and it's really important we think about the language we're using here. There's a wonderful resource anybody should look up called the People's Charter, which is actually about positive, non-stigmatizing language when we're talking about HIV. We don't talk about HIV infection, we talk about HIV acquisition. We don't talk about mother to baby infection. We talk about vertical acquisition, we've got to be really careful in the language we're using so that we're destigmatising, and we try not to use terminology sort of like disclosing diagnosis, because equally that has negative connotations. We talk more about sharing. But go back 40 odd years from HIV acquisition, before there was effective treatment, on average 7 to 9 years later, people would then start to develop opportunistic infections, be severely immunocompromised, and that's the point at which people at that time very commonly would have received a diagnosis of AIDS. Now we start people on effective treatment as soon after diagnosis as they are now ready. So that's why that AIDS term has sort of left our vocabulary, and because for people that during that time that are long-term survivors, it's really triggering, because they will have lost many of their cohort of friends and relatives and work colleagues. So, you know, we're in a completely different era now, and we need to get away from, you know, we won't go into the Thatcher government because it's not the right platform for it, but the damage that was done by well-meaning health promotion campaigns at that time, I think the legacy of that lives on. I think, is that fair, John?
Yeah, absolutely, yeah. And I support a lot of people who still hold on to quite strong internal stigmas, and live in total fear of anybody finding out, and even now, and it's held their lives back. And you see people who've been sort of disadvantaged in their social life. They've lost friends, and that's not because their friends don't want to. It's because they've chosen to pull themselves back, because they're so frightened of talking about it, being confident about it, and yeah, for fear of, you know, frightening other people and loved ones around them as well. We've had people who are disadvantaged from from getting meaningful employment, and obviously, you know, if you're not in meaningful employment, then all the other things around you might fall apart. And me and my colleague Peter, we often say like HIV is just this little tiny little thing, and it's like creating such a massive like issue for people when it shouldn't do. And it's like Emma said, it's a managed condition. It's there's no cure at the moment, and we see things are progressing that way. But yeah, you can live with it, and you can have it. You can actually, you know, from my own experience, I remember when it came, they call it the Lazarus effect, when you come out of, like, when I started to respond to the treatment, and then came back, I felt like I was strong as an ox, and I always have done. And I don't know whether that's just a benefit of the medication that you're given, but my immune system is so like robust now. So, you know, there is a silver lining in some ways, you know. Yeah.
I mean, one of the things that just made me think then, in terms of what Emma was saying about healthcare professionals. So I can remember being a nurse in the 90s and working on a surgical ward, and it was a 32-bedded ward, and we had one side room which we actually put this young man who was an actually IV drug user, and he was actually having surgery for valve replacement was what he was for. And I got to know this lad, and it was just interesting sort of talking to him. So he was younger than most people. It was a male ward, so he was younger by a good few years on everyone on that ward. And I can remember when he went down for going to theatre, all of a sudden the porters came with their trolley, and then they were all gloved up, aprons on, and they were only taking him to the theatre on the trolley. He had no connections or in terms of any drips or anything like that. And I was astounded. It was almost like they rang a bell coming on the ward, and I was outraged. I got to know this lad, and I was really shocked that they come on. You can imagine on this ward, people could just see that all of a sudden they were gowning up, where they never did that for all the people that were being taken to the, for surgery, going to theatre. They would just come and get them. But for this lad, they made a real song and dance of it. So I was outraged, and I went to complain. I spoke to them because I knew these two blokes, so I spoke to them. And what was interesting, and I guess it sort of undermined what my protest in a sense, it was the sister on the ward that had warned theatre, when you come in to collect this, make sure you're gowned up, you have all full protection, protective equipment and stuff on. So it was actually the sister on the ward, and I was just thinking it was somehow from the theatre, but it was from the nursing staff. So I think, what the point you were making there, Emma, is right in the sense of, I just think there's a job to be done with healthcare professionals as well as part of it. And my experience from the 80s is this was, the gay plague, that was what it was talked about. You think of James Anderton, who was the chief constable of Manchester, who sat around all Canal Side. 80s was obviously big important time for me, but I remember it was AIDS then in terms of that, and it was a serious, obviously fatal disease. I went to see that film on Monday. Peter Hoo-Ha's Day, who was the photographer, American photographer, photographed all the stuff around the Warhol years and stuff in America, 70s, 80s, died of AIDS, HIV. And Ben Whishaw plays him in terms of that role. And what he says is interesting, because when Ben Whishaw actually says, we've lost the generation. So for those people in the 80s who had this diagnosis, that's what happened. And he says for him, I'm not sure how old he is, I would say he's in his 40s, Ben Whishaw, perhaps in his 40s, but there's a whole, people would have been his peers, mentors, the contemporaries that have died because of it. And it's because of that ignorance, the scaremongering that took place. So the chief constable, I wrote it down and remembered it, and I have twitches when I think back from the 80s. We are swirling in a human cesspit of their own making. This is what he said about gay. So for homosexuals, prostitutes, drug users, they are swirling in a human cesspit of their own making. So that was the chief constable of Manchester. You've said Thatcher, it was the gay plague, the editor of the Daily Mail, Derek Jameson, it's a gift from God. That's what they were talking about in terms of HIV/AIDS. So it is. You look back to any of the things that we've had in the past, any plagues, it's God's vengeance. So there's been that. And in the 80s, 79, it was first diagnosed. The cost of that scaremongering, that's why it's so lovely to hear how much has changed and why language is so important. So we learn from that absolutely horror and scaremongering, ignorance and absolute hatred from people that are in power to have actually changed. And I just think that's what's lovely to hear, is that people are living with it in terms of with HIV. And as you said, I just love the fact that you said it's an honour, you said it's a privilege in your roles, and that's why it's dead important to actually challenge all of that hatred and discrimination, because that's what it is. And it deserves, and as healthcare, it saddens me that anyone would discriminate for anyone. You treat someone as though, I always think, it's your family, don't you? Do you know what I mean? And you want the best for them. So healthcare, I think we've got a duty and responsibility. Sorry, I've rambled on a bit there.
Have changed significantly, but I do think stigma remains the greatest challenge. And I think because of the reasons you've touched on, Ian, that's very often while people that maybe have lived with this diagnosis for a long time are apprehensive of healthcare professionals because of the way they've been treated historically. It's just the face of HIV care has changed tremendously. We know that since 2016 as a minimum, people on effective treatment. So if we look at the UK, we've got 95% of people living with HIV diagnosed. And of that 95%, 98% are engaged with care, and of that 98%, 99% have an undetectable viral load. If you're living with an undetectable viral load, you cannot share your HIV. You can have all of the unprotected sex you want. Not that we advocate that at all. We're not advocating that. We're not getting that, advocating that. But there is zero risk of onward acquisition. And sadly, in healthcare, very commonly, many people still don't know that. And that experience you talked about, I reflect on somebody recently who told me at their dental appointment they were turned away and told to come back at the end of the day so they could clean properly after they'd left. And it's heartbreaking, because you think, well, do you not clean properly after everyone else you see? But actually, your diagnosed person who's taken responsibility for their own health in getting diagnosed and is on effective medication is the safest person in that dental practice. They're safer probably than the dentist and the dental staff who possibly have never been tested. And it's difficult to hear that although I like to think there isn't the level of discrimination you talk about there, Ian, it definitely is still there. It definitely is still there.
Just around that, I've actually used this. And that's why I think the importance of this podcast, like, you know, or yourselves, whatever, just educate, get it out there. Because I've done it with students, both pre and post-reg, whatever, and I say about patients who possibly are HIV, and it goes, well, why do you need to know? You know, I'm doing handover, why do I need to tell you this? And they get really shirty with me. I need to know that. I'm going, why?
No.
You know, those kind of things. And not still today. So this is why. I
And,
want to thank you for coming
to
in.
those students, that patient's not HIV. That is somebody living with
Yeah,
HIV.
yeah, exactly.
That person
perfect.
is a lover, a brother,
Yes.
a professional. Do you know what I mean? There's so much more than their condition. You won't go in and say that patient's asthmatic.
Yeah.
You know what I mean? We don't talk that way.
The percentages you've just said then with regards to the, 99% of patients are well controlled, undetectable. I don't think any chronic condition in this country you could say the same about.
Absolutely
asthma
not.
being one.
No.
Asthma in this country is not very well controlled at all. So it's a case.
I'd rather have this than diabetes. You know,
agree.
that's what I always say.
Yeah.
Agree.
Absolutely, yeah. Because I mean, we all know what happens with diabetes if you're not managing it well. So yeah, I'd rather have this any day. And you know, you do sort of get like a really good, good access to the healthcare itself, you know what I mean, within the clinic. I mean, I'm really lucky because I work in the clinic as well, next to the fantastic team of, HIV clinicians and all of the doctors and nurses in there, and one or two of them treated me back 16 years ago, and I'm working alongside them now, which is just like, you couldn't write that, that's fantastic. So, but part of our work is going on to the numbers as well, because the last sort of marginalised people or group of population that we're trying to target now and get into HIV, into care, and getting treatment is those. So that's why we're doing the opt-out testing in emergency department now at the Royal and at Aintree, and I think there is talk of trying to sort of expand that a little bit more into other healthcare settings. We did actually pick up a new diagnosis of somebody in urology at the Walton Centre, which was just a fluke test, so these sort of places do need a bit more of that going on. I think it's not just we don't get new diagnoses of the gay community anymore. We just don't see it.
So we're at 95% of the UK's population diagnosed, but that 5% undiagnosed are hard to capture. Historically, people think, as Ian has mentioned, as John has mentioned, about this being a disease affecting gay men, and actually we know that rates of acquisition until recently have dropped significantly since 2015 in that group of people, and that's largely due to PrEP. So for people who aren't aware of PrEP, it's antiretroviral therapy you can take to stop you acquiring HIV, and that has been a game changer, in preventing HIV acquisition. But that 5% of people undiagnosed are tricky to capture because they're not what was historically seen as high-risk groups.
I was going to say that, high-risk group.
Rates of acquisition amongst white heterosexual women over the age of 40 are rising, and that's because professional white women don't see themselves as at risk, and yet actually anybody who has had unprotected sex, has had children, anybody is at risk. So the opt-out programme that John mentioned there was started as a trial across some of the major cities in the UK where we have the highest number of people living with HIV, so Blackpool, London, Manchester, Birmingham, I think, from memory. And it was a trial programme testing everybody who was coming into A&E that was having blood tests done, an HIV and blood-borne viruses test, so looking for things like hepatitis, was off. In fact, it wasn't offered, it was done, it was an opt-out, and there's information on the walls around A&E so that people could opt out if they wished. But we don't ask people for permission to take a full blood count, we don't ask for permission to do other blood tests. And actually the research that came out of that, the number of people that are either re-engaged with care, so people who had maybe been diagnosed previously but for whatever reason had fallen out of HIV care, or the people that it diagnosed newly, the numbers spoke for themselves. So this is now being rolled out nationally, and as John says, we're doing opt-out testing in Liverpool and in Aintree, and it's something that we will see, you know, right across the country to capture that undiagnosed 5%, because by virtue of the fact they're undiagnosed, they're more likely to present to A&E with health complications, opportunistic infections. By targeting people for HIV tests, you know, I think of a man I support living with cancer. He was offered an HIV test. He had swollen lymph glands at diagnosis. But without a doubt, he was offered an HIV test because he was a gay man. And actually, if that was a straight woman in her 70s, would she have been offered it? So we're stigmatising in terms of who we offer HIV testing to. We need to make this very, very normal for everybody.
Yeah. Definitely. Yeah, like I said, I mean, for the gay community, especially gay men, they're very well educated. The vast majority of individuals take care of their sexual health and are not afraid, and there's no embarrassment, you know, by going into the clinic and do these things. So, like I said, most people, you know, are on treatment now, like myself. So that's not a problem anymore. And then obviously there's people that, you know, access PrEP and those sorts of other things as well, and also going for regular testing as well, you know, not just for HIV, but for other things that you can catch through sex, you know, that's also important. Yeah, like we said before, a lot of people do always say to me, so when can I have sex without condoms? I'm like, I can't really tell you that, really. You know, because when someone's newly diagnosed, we need to make sure that the viral load is down, and also the CD4 count is up, so that they are classed as then undetectable.
So viral load is the level of the HIV virus in the blood, and the CD4 count is essentially your immunity. So we want you to have good immunity and undetectable levels of viral load. Yeah.
But the thing that always got me as well was with blood transfusions, just, you know, actually donating blood. Just like, oh no, you can't. You cannot give blood. You know, that was the case. And I was just thinking, I know, like, you know, heterosexual people were probably more at risk and things like this, whatever. It's just getting me tits, man. I'm sorry.
I just want to mention as well, because we've said stigma so many times in the first 20 minutes, and the reason we set up the Manhog originally was obviously we want to try and reduce stigma around men's mental health and coming forward. And I think what we've learned in like the first 3 years of doing this podcast is you can easily just replace that word stigma with ignorance, and it's exactly the same, can't you? And I think everything you're saying here, you know, you said that the gay community have got a really good understanding and education of it, and that's brilliant. But the rest of the population and the general public may be lacking that knowledge and may be lacking it, and that's where this ignorance comes, and then hence stigma as well, really. So yeah, I think so. For HIV Testing Week next week and events like this, they've got to be really key in educating the public, haven't they, really?
And really, you know, there was that huge campaign of the 80s. There's never been anything to redress that, to say, actually, look where we are now. You know, the population and men that have sex with men, gay community, I appreciate not everyone would identify as gay, you know, are really well informed and proactive in their healthcare predominantly, but actually that's due to the community themselves and good health promotion via social media and dating and hookup sites. It's nothing that's been done outside of the population of people themselves. So I kind of feel there needs to be a refocus on that. Just
on that, Emma, one of the biggest campaigns in the UK for mental health was the Time to Change campaign. You know, and what that did is it got I want to say famous faces, popular faces, to talk about, oh, well, I've got, you know, obsessive compulsive disorder, I live with bipolar or whatever it is, or live with depression. So obviously we had people like David Beckham and Stephen Fry, all of these faces just openly talking about it. And what it did is it reduced that kind of anxiety for people to go, well, I can talk about it then if they can. And it's gradually worked, and we're seeing that huge shift in it. So I'm thinking now, you know, with people like Gareth Thomas, for example, who openly talks about living well with HIV, do we need more of that focus, that kind of, you know, them campaigns of people living well with HIV?
Yeah, definitely. I mean, we at George House Trust, we do that anyway. I think we do that really well. There are other organisations that do the same. So, yeah, but as I said, with George House Trust, it is quite localised to the northwest, so Manchester and Liverpool mainly. But yeah, we do work alongside other partners, you know, to expand that message. I myself, I do positive speaking now as well. So I done my first one. It was an online one, you know, on a Teams thing. So it wasn't really in front of a big audience, but I will be doing something next week.
Online is
It
hard.
was, yeah, because I really couldn't gauge what people's thoughts were, because all I could
done.
see was blank faces and or a nothing
screen.
blank screen, you know. So, but the comments I got afterwards were amazing, you know. So there is always that you know, yeah, I couldn't fault that really. And I'm doing something next week. I'm just going to talk for a few minutes about my experience at the Fast Track Cities sort of thing next week. So that's in Toxteth Town Hall. So that's going to be.
Yeah, and your role, I mentioned it to you. You know, when I worked in mental health, we developed this role called recovery mentors. So it was young at the time, it was young males who had experienced psychosis, and then they'd got back to university and all the rest of it. And we got them employed by the trust, so that if anyone else was experiencing it, we could take them out to talk to the family and to the people going through that experience. And it was such a powerful tool, because people just think that their world is over as soon as they get a diagnosis of anything, don't they? And especially parents who are really worried. But then you've got someone there going, well, actually, I've had it, and you know, I'm now working with the trust. I'm doing that. So your role in particular for that, how powerful are you seeing that when you're working with people?
Do you know, like one of the I try to explain it. It's really hard to explain and try and articulate what it feels like when you walk into a room and you've been told, okay, we'd like you to speak to this person who's just been diagnosed with HIV, and they're happy for you to come in, and they come in and speak to them, and you walk in. It's particularly, I had one guy who was on the ward last year. He was late stage, you know, HIV, and he was suffering with lots of other complications because of it. A person that would never have thought that he was at risk of anything like that. I walked in, first thing I said was, I live with HIV as well. And you just see the weight just disappear and the worry disappear off that person's face. At first they're thinking, who's this person walking in here, you know, just like all happy and that, you know, I'm confident about it and stuff. And once they see that, and sometimes that I'm the first person that they know of that is living with HIV and is open about it. So that in itself can be just... And literally, I've had one guy who came in and he'd stopped taking his medication because he felt like it wasn't his decision to decide his fate. It was his fault he got it, which you see quite a lot, to be fair. Which really awful to see. I never experienced that feeling myself. But like, you know, as soon as I've just walked in and said, okay, so you're here now, you're engaging with us now, you know, and just to tell you that I live with HIV as well. And I've never seen that person again since. But I do know from the clinicians who tell me that he's doing really well, and he gave feedback to say, you know, it was one of the most powerful things he'd ever experienced, and it fixed all of the issues that he had in his mind, and he's now carrying on with his life. Never see him again. And that's perfect. Yeah.
Peer support is as crucial in this as, you know, the medications and all. You know, it is an absolute game changer, because as a health professional you can tell someone you're going to thrive, you're going to live a great life. Don't believe you until you meet somebody like John and his colleagues who actually really show that lived experience. It's the biggest game changer, and we are so appreciative of, you know, the work of the third sector and people with lived experience, because it is a game changer.
And we advocate for people as well, where people don't feel confident in putting that first step into dealing with something to expand their life, or to make steps to do things better, or to you know increase their quality of life, or to reach their goals and things, you know what I mean? So we do get a lot of issues with people around housing, benefits, you know, employment, disclosure with their family and friends and things like that. We can talk about things like that. Quite often people say, when can I tell? Oh, I need to tell so-and-so, I need to tell so-and-so. It's like, hang on. Just hang fire. You don't have to tell anybody. Yeah. It's not something that you need to be thinking about straight away, you know.
Psychological support as well.
Yeah, we provide counselling services, all those sorts of things as well. We do peer group sessions as well, where we invite people to come along in a safe space where they can talk about their own experiences with other people. And you often find a lot of people living with HIV as well are isolated. And that's a big thing for myself and my colleague Peter. We're really big on that side of things, really, and we want to get rid of that isolation and help people make connections. You know, people who've lived the same thing, and you do see that, and it is lovely to see. Yeah.
Brilliant. We'll come back to giving a good plug to George House Trust at the end as well. But just at the moment, for this podcast dropping during HIV Testing Week, so just a little bit about what's the purpose of National HIV Testing Week, or why is it there to kind of raise awareness?
We're trying to find that missing 5% to engage them in care, or people that have fallen out of care. We are never, ever here to judge, and we recognise that sometimes life is unpredictable, life is chaotic. We're here to listen and to support. We're never going to force people to do things they don't want to do. HIV Testing Week is a great opportunity to raise awareness of testing and to promote the fact that you're better to know than not know, because you can then live a normal, fulfilled, active life. I think HIV testing has come an awful long way over the last 2 decades.
Yeah, I mean, it's about normalising it.
Yeah.
Just making it, feel normal. So that's a normal, regular thing that people should be doing. If they're sexually active in particular, regardless of whether you are in a relationship or not, we would say, get yourself tested. You never know, and you'll be grateful that you do know, and that's one of the biggest comments. I think through the ED testing, we had about 11 or 12 new diagnoses last year from the Aintree and the Royal, and pretty much every single one of them have said that they're really thankful that they were that it was done, and they're really grateful that they know. And they know they can now,
I guess for some people it's that whole thing that they may suspect, or they may, be thinking, but they're too scared or frightened, I guess, in terms of actually getting that tested. So I guess that's an opportunity, isn't it?
People have
confirm
lived with, people have been unwell, they've felt rubbish and had loads of different symptoms, and they're back and forward to the GP, and they're worried because they know they're not right but can't put the finger on it. And sometimes actually, this is what it is actually really reaffirming and anchoring.
But I also think it's important, as you said, for everybody, because whenever it comes to sexual health and things like that, we always think it's the younger population. But as you quite rightly said, you get people who are divorced and then, they're going out having different partners and things like that.
Postmenopausal, pregnancy risk
all
drops.
those issues, things like that, heading off to places.
Cruise ships.
Cruise ships.
That's based on no evidence, I should say.
Let me just make a note of that one.
There was no evidence behind that comment.
There was a thing with Saga Cruises. There used to be an acronym for sex and group. I don't know what it was. There was something I remember reading about that. But it's around sexually transmitted diseases within nursing homes and things like that, the population going around, and so everybody. That's, I think, the important thing to get across. And fair play to them at that age, still being allowed with that. Doing the biz, respect.
50% of our HIV population in the UK are now over the age of 50. So, my best friend manages a care home chain, and actually they've never nursed anyone with HIV because historically people didn't live long enough to reach old age. So there's education needed, but testing absolutely. Testing is free, and it can be done via sexual health clinics where people can go and normally get their results within a few days. But actually you can also order free tests online. You can pick them up. There's saliva HIV testing, there's finger prick blood testing that you can do at home, or there's tests you can do at home and then send off, and you will be contacted with the results. So, testing has become accessible in whatever way people feel most easy to get it.
I suppose this is a bit like World Mental Health Day, it's not just one day of the year, this is every single day, isn't it? So I suppose it's the same for HIV testing.
And regular HIV testing, I think if you're somebody that's, maybe not within a long-term monogamous relationship, we really advocate regular testing every 3 months for people that are living their best lives, to help them to enable to do that. Yeah.
So for that week then, for the events and activities, what sort of happens then in that week? How's that what does that look like then in terms of all the
so
the
as
things?
far as George House concerned, George House Trust, we are going to be or we hope to be, well, we're promoting 6 different centres. I can send you the details of those, can't think off the top of my head, but there'll be certain places around the city that people can go to that are being advertised as a place to go on certain days. I know Sahir House are doing the same, so we partner with them quite a lot within the city region. So so they're doing a pretty similar sort of thing. But like I said, you can ask any medical professional, can I get a HIV test, and that can be done for you.
GP
at any
practices.
GP practice. Anywhere
GP
you go.
practices, any sexual health clinic.
Yeah.
I get a lot of patients come in that are, bunch of widespread condition, symptoms, tired all the time being the general theme behind it all, and we generally do a full blood count and generalised bloods, but we wouldn't go straight in there with a HIV test. But it is a consideration. I suppose if the haematology comes back deranged, then it is then what the next step of bloods we would do. But I get a lot of gentlemen coming in more recently, really asking for testosterone tests if they're in the mid-40s and finding that they're tired and whatnot, and loss of libido and all that. So I suppose there's no reason, like you say, why people can't come in and just say, I'm concerned about this, I'm worried about this, I've been for a while, is there any chance? And once that question's asked, then the healthcare professional is obliged to say yes or explain why they're not willing to do that. So
the quicker you get tested, the quicker you get on treatment, if you get the diagnosis, and it's not the end of the world. And that's what I want to just get across to people, that it's not the end of the world. Yes, I've told you my story earlier on, but that was a pretty horrific experience, you know what I mean? But people don't go through, like Emma said as well, we don't see that type of thing going on anymore. It's very, very rare that we see anybody go to that stage these days.
So you say that the testing has improved and changed over the last sort of 10, 15 years to the point, you kind of said it really, that now most people are regularly getting tested every 3 weeks.
113,000 people living with HIV in the UK. And John mentioned before Fast Tracks Liverpool. So the Fast Track Cities programme is a programme set up by UNAIDS, isn't it, to try and get us to 0 new HIV acquisitions by 2030.
Yeah.
So we're only going to do that by improving testing. Now we appreciate, even if we get to those figures, and the UK has made incredible progress, it's important to say, even if we get to those figures, we've still got 113,000 people thriving with, ageing with HIV that we need to look after. And we know that although we aim to get to 0 acquisitions within the UK, that we have people coming into our country, offer amazing support throughout our workforce who will be living with HIV. So we've got to make sure we've got robust services for those people. We've mentioned PrEP a few times throughout this conversation, and I think it's important to say that PrEP is free of charge, as is HIV treatment for those who are diagnosed. And PrEP is accessible for anybody, irrespective of gender orientation, irrespective of who you're having relationships with, how you identify. Men and women can access PrEP through sexual health clinics, and we hope at some time in the near future, possibly pharmacies, but we're not quite there yet.
Yeah, that's true.
And there's 112,000 people accessing regular PrEP within the UK to prevent HIV acquisition. So I think it's fair to say that's predominantly within a population of men that have sex with men, and really want to promote that actually women, this is here for us too. We do need to look after our broader sexual health as well, but it's something to bear in mind.
Yeah, definitely. Yeah. Also, just to mention that there is injectable HIV treatment now. So you don't have to have the tablets if that doesn't fit within your lifestyle. We do get a lot of people who did jump over onto the injectables, and they were people who have lived with HIV for a long time, where the medication that they would have been given, when first medication was available, it was quite toxic, and it caused a lot of issues, side effects, and quite nasty side effects, and long-term use of those medications has affected, their internal organs, in particular their stomach, and
esophagus.
Yes, that. Yeah. So yeah, and it's caused concern, issues with that and deterioration in those parts of the body. So having the injectable option has just changed their lives and meant that they're not causing any more, issues on the internal parts. Yeah.
So I think in early days, people could be taking, I was talking to somebody last week and he was telling me he was taking 30 tablets 3 times a day when he was first diagnosed over 20 years ago. And then treatments evolved massively. For people on oral therapy, for a lot of people, that's just 1 tablet a day. But injectables, I think, are really revolutionising HIV care. So not everybody will be suitable for injectable therapy, but for those who are and who want to go onto it, if you're happy on your oral treatment, fantastic. But this is a intramuscular injection once every 8 weeks. So it for many people, there's so much self-stigma within HIV care. For some people, I don't know if that's fair to say, John, and the people you see and support, that actually that daily taking of tablets, often that's why people can fall out of care, because they just get pill fatigue and it's a daily reminder. Whereas actually if you can go once every 8 weeks, quick jab, done, and then you can forget about it.
We've had that
and
for
certain
years,
times
a
depot injection,
monthly, 6-week injection. It's because of that, just so that people can get on with their life without having to remember to take so many
and I've been
tablets a day.
surprised how many people actually say, actually, no, I preferred the oral therapy. But
I do. I
there's
prefer
choice,
it.
and it's shared decision making, isn't it? I think that's what's important, getting alongside somebody and understanding where they are and what their priorities are as to which treatment pathways can
I
suit
see my
them.
pill every day. It's my little lifesaver. That's keeping me going. That's keeping me going every day. There are concerns, obviously, if you have a busy lifestyle or for people that might be a little bit more carefree in their lifestyle, like you can miss doses and things like that. Obviously we don't recommend that. But the medication now you used to have like multiple tablets, but now most of them are 1 tablet. They could contain 2 or 3 different medications within that 1 tablet, so that makes it a lot easier. And a lot of the ones are now where you don't, in the past you'd have to have a good meal with it, because to help with your stomach or absorb it, I don't know, but now a lot of them are just, you just take any time of the day. We do recommend obviously taking it as much to close to the same time each day where possible. And we're not seeing the negative side effects in clinic anymore. When I've spoken with the bloodborne virus specialist nurses, they just don't see people coming in with all of the other things that, the past medication has caused people. And
if you're living with HIV and not getting on with your medication, talk to the team. There's masses of options. There's always options.
What about the likes of communities, workplaces, universities? Is there anything they can do to get behind the campaign?
I'm actually going to be at the University of Liverpool on Saturday, so I'm going to be doing a talk about sort of trans people and their barriers to healthcare. And I've got one of our volunteers, she's lovely, so she lives with HIV and she is trans, and she's going to be joining me in that as well. So again, it's about trying to access those marginalised communities or people, because when we look at some of the research we've done quite recently at George House Trust, is that in particular for trans people, they are very underrepresented in the healthcare systems and access to health and all those sorts of things as well, and for HIV care as well. We don't actually even know how many people identify as trans within when they come into clinic. They're not asked those questions, so we don't even know whether the numbers are right or not. But we do know the numbers that we do have, there is a lot more, that we don't know of.
There's a disproportionate number of trans women living with HIV,
Yes.
so we've really, and there will be trans men living with HIV as well, but we see particularly more women. So we've, there's enough barriers to accessing healthcare, isn't there, if you're not from a majority population. So I know in work that we've done in Liverpool, with our population of people living with HIV. You know, I personally, and it's only a personal thing, I don't like the term marginalised groups or hard to reach groups, because I think we don't have hard to reach groups, we just have inaccessible healthcare. We expect people to fit our 9 to 5, largely English speaking model of NHS healthcare. And actually it's about getting our care to the people that need it most. We know our local footprint of people. We have high numbers of people living with poor mental health, living below the poverty line. A number of the people certainly that I support in my clinical role don't have English as their first language, maybe living with uncertain immigration status. And actually, your HIV probably isn't the most important thing in your life at all. That's probably the least important thing.
Yeah.
So it's how can we make our care accessible for people who maybe don't find it. These are all barriers for healthcare. These social economic sort of challenges are all barriers for people accessing healthcare. So it's how can we get our care to people where they need it, when they want it, you know.
Yeah, and it's just going back to that point, it's about open doors. People from the community saying, come in and, you know, have these sessions like you're going into universities, you know, and just, if we're ever going to get anywhere and say, you know, sort of improving the education of the public in particular, that's kind of what we need to do, isn't it?
Yeah. And I do think, kind of, you mentioned there about universities, as did John. I think, you know, our generation, you need to assume everybody's age in the room, but do you know what I mean? We're aware of this. Yeah, some of us are more aware of it than others if we've lived longer, Ian. But actually, you know, when I look at my godchildren, they're like, well, why is this a big deal? It's just 1 pill a day. It's no biggie. Well, actually, it is just 1 pill a day for many people, but actually, it is a long-term condition that has huge impact on people's lives. So it's almost re-educating people that this is a risk and what you need to think of, because certainly, you know, my young 20s godchildren don't.
Yeah. I suppose that the signposting is just as important as well, and isn't it really? So that if you've got someone who maybe come to university living with HIV, maybe from another city, it'd be nice that they know where to go for that peer support, isn't it? You know, and we see that with all mental health conditions as well. You know, final big plug for George House Trust. Then, so you know, if anyone's listening, and they feel like it, you know, access the support. Tell us a little bit about it. It's amazing.
It is
amazing.
I mean,
it is amazing actually. Amazing. I mean, it wasn't a difficult decision for me to go for the role. Basically, I had to. Without George House Trust, you know, I don't know where half of these people would get anything at all if they didn't have it. It's a difficult. I always say, if this person didn't have HIV, they would have no one, because of the issues that they've got around. You know, because sometimes, like you just said, then HIV's not the big problem in a lot of people that we support. It's other things, you know, around it, so that we support them with. The battles that I get involved in, you know, to try and advocate for people are just, you know, and getting the results out of it, that's brilliant, you know, and we can do that for people. But it is also about getting them to also live confidently themselves, and making those steps themselves and pushing them in that way. But yeah, George House Trust is, as I said, 40 years anniversary last year. Amazing organisation, and yeah, I work with some amazing people. You know, we are all, you know, so we all support each other. There's always somebody we can go to if we need our own support as well within the organisation. But sometimes it's the case, because sometimes it can be some sad stories and some you know difficult situations that we get presented with. But yeah.
There's nothing you can't support, is there? Whether people come to you with work issues, financial issues, sexual health issues, need for counselling, it's an all-encompassing...
Very holistic, you know, the way we approach it, really. Yeah. So each person gets dealt with on an individual basis.
Amazing. Yeah. So do you think there might be people living with HIV who don't know about support like this?
There quite possibly will be. I mean, I know that there are people that have been told about us by maybe the clinician, but then they've not engaged with us. You know, try again. you know, see what that can do for you. If you're still, you know, having the issues, if you've still got that stigma, if you've still got those worries, write those things down, come along and we'll thrash it out.
Amazing.
In confidence. And I think
Absolutely,
that's
yeah,
a really important thing to get across, because people are apprehensive about that, aren't they? It's completely confidential.
Yeah.
Having supported, I was asked to support an event for George House Trust doing some education a fortnight ago. I've got absolutely no idea if it was any use to the people there, but what I took away from it, like, I just felt my bucket was full, and it was the sense of community and friendship and support. And actually nobody mentioned HIV once during the day because it just wasn't relevant. It was just a group of people with each other's backs, and
Well, the worst thing I've really heard today was that you had to stay 4 months in the Royal. Like, you know, I used to work there, and I was just like, frick.
And that was the old Royal.
That was the old Royal, I know.
And I had to look out at that horrible car park.
Yeah.
You know, at the back where the new hospital is now.
Yeah.
So I had to look at that car park every day. And one day, this doctor came in and said to me, if you don't respond to treatment now, we don't know whether we can carry on any further. And he's telling me that as I'm looking out this car park. And all I kept thinking was, I'm going to die looking at this horrible car park like in front of me, you know. And that was my worst worry. That was the worry that I had at the time. It's strange, yeah.
Well, John, we can't thank you enough for coming and sharing your story. You know, it's everything that we do on the Man Hug here is, you know, just normalising the experience. So thank you so much. Thank you for the amazing work that you guys do at George House Trust as well. You know, you've sold it to me. It sounds absolutely amazing. To anyone who is listening who feels he might benefit it, please try and reach out to George House Trust. And Emma, your expertise, thank you so much. All of these stats and data which you were just pouring out with no notes, you know, it's, amazing. But I think, you know, I've learnt a lot from this podcast alone, and I'm sure everyone else has, and I'm sure the listeners will as well. So, yeah, from all of us, thank you so much for being amazing guests.
Thank you very much for having us. Yeah, thank you.
We can all play a role in suicide prevention. Spotting the signs and starting a conversation with someone you're worried about can feel daunting.
But free online training from the Zero Suicide Alliance could help you gain the skills and confidence to have a potentially life-saving conversation.
It takes just 30 minutes, and you never know when you might need to use it.
Be prepared. Take the training today. Visit zerosuicidealliance.com or search ZSA Suicide Awareness Training, because one life lost is one too many.
If you or anybody else you know is struggling with their mental health, visit hubofhope.co.uk or download the app today and find local and national mental health support.
Thanks for listening to The Man Hug. Please make sure that you come and follow us on Instagram. It's @The Man Hug. You can also do a search for us on TikTok and YouTube.